Thanks so much, and I'm really delighted to be here at this inaugural conference, and it's fantastic. We've had really warm support from Jill and Harry since the inception of Healthwatch England, which is a new part of the health and social care landscape. So what I'm going to talk about today is a little bit about what we do and what's coming up through our Healthwatch network, and give you a flavour of our work going forward, and particularly our work around informed choice and education, which I think will be of particular interest to you. So Healthwatch England was set up in October 2012. I've been part of the organisation since last January 2013, so about 14 months now. And it is a unique concept. In fact, it's the only part of the health and social care system that is dedicated to think about health and social care from the point of view of the individual. The only part. It is an extraordinary fact that we have a health and social care system in which institutions are well represented and professions are well represented, but there is only one part of the system whose job it is to think about, sole job it is to think about what it feels and looks like from the point of view of the individual. And one of the reasons we were set up was, and obviously I arrived, I think, 2 weeks before the Francis inquiry was published. And I thought at the time, either my timing is exceptionally good or absolutely terrible. And in fact, what the Francis report did was make the case for Healthwatch, I think, very, very powerfully. So what Mid Staffordshire, Morecambe Bay, Winterbourne View all have in common was the fact that people were voicing concerns, in fact, for a very, very long time, about the health services and social care services that they were receiving, but the system just wasn't listening. So Healthwatch's principal role at both a local and a national level is to make sure that the voices of the individuals using the system are heard very, very powerfully and strongly. We have some statutory basis to do that. So at the local level, Healthwatch have a statutory place on the health and wellbeing boards, which means that they should be there influencing the shape of services for the future. And at a national level, we have advisory powers, statutory advisory powers over the NHS England, the Care Quality Commission, monitor every single local authority in the country, and the Secretary of State himself. And whilst we cannot make anybody do anything, all of our advice is a matter of public record, and anybody that we give our advice to is obliged to respond to us on the public record. So we think that that's a pretty powerful tool. We also have other statutory tools at our disposal. For example, we can launch special inquiries, and the very first of our special inquiries, which is on discharge, an unsafe discharge from institutions, with a particular focus on mental health and what happens when people are discharged from mental health institutions back into the community. That's just about to be launched and will be concluding this autumn. Starting and ending with people, as we do, actually gives us a very interesting perspective, and something I'm sure that is very dear to all of your hearts, which is actually, it gives us, when you start and end with people, you think about people as a whole, and they think about their health and well-being in quite a different way from the way that health and social care is set up. So whilst we've got a responsibility where there is risk in the system and where there are problems to alert people to them, we also have a responsibility to make sure that the future system is shaped around people's needs. And in the work that we've done with the public, it's very clear that in 2014, people's understanding of health and well-being is a broad one. And actually, we've got a service, as many people say, that is an illness service, not a health service. And in fact, the bigger challenge that Healthwatch poses is about changing the dialogue and changing the culture around our health and care provision to start with people's needs. It's a big agenda. We have responsibility for all children, young people and adults in England, and we are responsible for both health and social care. So it's quite a big agenda. But in that agenda, we are supported by a fantastic network of Healthwatch in 152 localities across England. So every local council has a Healthwatch. Mine is Healthwatch Lambeth. If you want to know where your Healthwatch is, you just need to come to our website at healthwatch.co.uk, pop in your postcode, and you will find out where your local Healthwatch is. And they are there to represent all of the individuals in their local authority and those people that are using health and social care services. So this network across the country gives us insight, so local insight, eyes and ears in 152 locations across the country. From the Isles of Scilly down in the southwest, and I've met the Isles of Scilly Healthwatch. They have a very interesting set of challenges, but quite different from Newcastle in the northeast. Those are our sort of geographical spans, where they've got inner city population, big and complex population. Isles of Scilly that's got one GP, and where you have to fly to the mainland in order to get access to scanning services, and where children at 16 have to be schooled on the mainland, and yet I think there's some issue about they can't get direct consent for their health services, so you've got to ship their parents over. It's all terribly complex, to a whole different set of complexities in Newcastle, where they've clearly been grappling with issues of public health and health inequalities for many, many years. So that's the diversity of the network, but it means we get really, really good local insight in 152 different localities. And what Local Healthwatch then do is feed up to us to make sure that we can take those issues up nationally. And likewise, we have a national overview. We look at policies at a national level, and we encourage Local Healthwatch to work with them at a local level. We don't commission the Healthwatch directly. That's all commissioned by the local authorities themselves. So it is a network of the willing. I understand from the technical people it's called dispersed leadership, which apparently is the best and most modern type of leadership, which I think basically means it's very, very complicated because we can't tell anybody what to do, but we can encourage them in the right direction. So that is really the power. So although we've got this absolutely vast agenda, we work together with the Local Healthwatch network in order to make change happen. And just to give a couple of examples of where this has happened in practice, where we've used our advisory powers, for example. So Healthwatch in Derby, in fact, raised for the first time quite some time ago some concerns about the information, or rather lack of information, around the new care.data programme, and as that was rolling out, we went back out to the whole of the network and said, is this an issue in your area? And true enough, they came back and said, yes, it is, and we'd like you to flag that with NHS England. And we did so. So we wrote to David Nicholson, and our concerns, along with the concerns of the Royal College of GPs, the BMA and others, were what caused him to make a pause in the rollout of the care data programme. And they're now working with us in an advisory capacity to make sure, or hopefully, to ensure that the care data programme rolls out with improved public information on it. As Jill was very kindly pointed out earlier, we've also been doing work on complaints. That's a work that we as a national body put on the table, and where we know that people feel very reluctant to raise concerns that they have with their health and care provision. So although many people experience issues, around a third having experienced, according to our polls, having experienced quite serious concerns with their health and care system, more than half will do nothing about that. And actually, there is an issue we have more generally with feedback. And I was saying to Jill before I came on the platform that it's a kind of crazy world that we live in, that when we've got feedback, positive and negative, about our fridge freezer or about our car mechanic, we find it easier to give, in fact, given more options to give it, than when we've got feedback around our health and care services, even though those matter much, much more to us. So again, what we're trying to do is create a positive culture where people see feedback as part of normal life, and complaints as indeed the gold dust of information within the system, and an openness and some signalling from all of those health and care professionals that actually they are open to have those conversations. And again, we've seen some very useful practices amongst Healthwatch locally as they've tested out. So I spend a lot of my time around here and in the Department of Health, where policy rules and people say, well, this is how it is on the ground. And actually what Local Healthwatch do is kick the tires on that and see how things actually happen on the ground. So Healthwatch in Camden, for example, sent a mystery shopper around all of the GP practices in their area. I think there are about 39 GP practices in Camden. a mystery shopper who just said, I'd like to raise a complaint just to see what the receptionist said. And I think of the 36 or 39, that there are about 6 were fully compliant with stated DH policy and practice, and the rest were on the scale between trying hard but not quite getting there to, frankly, providing a service that was absolutely not fit for purpose. So that's, again, the power of Healthwatch at a local level, which is actually in this sort of industrial scale service that we have, actually testing out whether what is said is the same as what is done. And it turns out that often it's not, and that's our job, is to point out the differences. So I hope you can see some examples of what Healthwatch have been up to across the country and working in a very diverse range of issues. So from a group of Healthwatch up around Liverpool who've been working to make sure they get patient transport services right, to Healthwatch in Lewisham who are working with young people's access to preventative mental health. A huge diversity, all good issues, but a huge diversity right across the network. So the thing that I thought would be of interest to you was our framework around rights within health and social care. We presented last October a framework of 8 rights, which reflects the NHS Constitution, but in fact goes wider than this, looking both at social care and at health, and really captures what the public think they should expect from health and care services. And it created a very rich and fascinating conversation, actually, with the public, because once you scratch the surface of this gratefulness for the health and care services that we're given, people actually have a very strong sense of their rights. And I just wanted to flag one, which is around the right to choose, and to flag to you what we're doing to support informed and educated consumer choice. We feel that it's really critical that consumers have the right, users of health and social care services have the right to choose from a range of high-quality services, products and providers. But that choice absolutely needs to be meaningful, which means that they need to have the appropriate information and education to support those choices. And where there are additional paid-for options, people should be told about them. We also recognise that not everyone wants to choose. Some consumers have told us that they would prefer it if the choice was made on their behalf, but in the first instance, everybody should be given the option of choice. What that means in practice is if you've been assessed as needing therapy to help you manage your anxiety condition, for example, you should be able to choose who provides the support and what type of therapy you get. If you're being offered a procedure, you should also have the choice not to have it. I had this conversation recently with somebody from the Association of, or British, what they called the Royal College of Surgeons, that's what they're called, sorry, who almost fell off his chair when I said, actually, the whole service is set up pro-intervention. But in fact, if you track people's own reports of how well they've done after particular interventions, a lot of people, and indeed the surgeons themselves, are quite surprised. So I'm sure you'll be familiar with some research that has been done, patient-reported outcome measures research that has been done on a limited number of surgical interventions. So they've done work on hernia and knee operations, those sorts of operations. And what's really interesting about that is actually people report, if you actually follow them up and ask them how that's affected their health and well-being, people report much less positive outcomes than you would anticipate. And I was talking to the person at the King's Fund who'd done this research, and he said he'd found somebody at last in the system who was actually using it. So a GP up in York who was using the patient-reported outcomes measures on hernia patients that he had. And he said that he'd spoken to 7 hernia patients who he had, and he'd told them these were the patient-reported outcome measures. And what they really liked was the fact that it was information that came direct from patients. So they felt it was credible and believable, it was properly scientific, properly evidence-based, but it was basically the views, capturing the views and evidence of the patients themselves. And of the 7 he'd spoken through with this research, actually 6 had chosen not to have the operation. And I thought it was fascinating because we've set up a service that is always pro-intervention. Now, the president of the Royal College of Surgeons almost fell off his chair when I said this to him. And he said, oh, yes, but what about strangulated hernia? And I said, but surely if people are making an informed choice about the risks, then that's their choice. If they're actually making a balanced and informed choice, then that's their choice. So I think that there's something in here actually incredibly powerful, which is about putting some of the power back in the hands of people and treating them as true adults in terms of making choices about the treatments that they have. So I just wanted to quickly conclude, just to give you a flag of the kind of work that we're doing over this next year. We'll carry on our work on the complaint system. I don't know quite what the question was that people were asking that led to more than 70 organisations potentially involved with your complaint, but it clearly wasn't the right question. And when asked, is that the right number, the answer has to be, surely it must be less than 70. We need to simplify the system, make sure that the system works for individuals. We're working in collaboration with the CQC to make sure that Healthwatch are properly plugged into the new inspection regimes. We're obviously working to support the network as a whole, and critically, and I think this is an area of particular interest to you, I'm sure, we're working to make sure the future shape of services is actually fit for people's needs, so that when the big debates happen around the integration of health and social care through the Better Care Fund, when the debates happen about reconfiguration and closure of local services, when the debates should be happening at health and wellbeing boards about the future of services, actually it starts from the point of view of what people need. It's not a complex idea, it's a very, very simple idea, but it's an idea that is quite foreign, actually, to our health and social care services as they stand at the moment. And we believe that if you begin the conversation with people and end the conversation with people, not only do you get a better service for those professionals working in it, you probably get a cheaper service because you allow people not to have interventions if they don't want to have them, but you also get a service that actually truly reflects what people want from it. And so that's the point at which I will end.
Thank you very much indeed, Katherine. And a huge amount of achievement there for Healthwatch for the very short time in which you've been in operation. And I'm sure there are lots of things that rang bells for people either operating in their local area or things that they want to talk about from national level. So Katherine is very happy to answer questions or take comments. And we have, as ever, our roving mics. Yes, we have. Dan, have you got the mic? Sorry, he hasn't got the mic yet. It's just coming. Sorry, it's just coming now. Have we got another one around ready for the next question? Right, so Nick, you carry on.
Sorry, I've been asking questions all day, so you're not alone. But firstly, your point about intervention, I think, is absolutely right. And I think, say in terms of acupuncture, for the organisation I represent, there's some really interesting research on if acupuncture is offered to people, say, going in for knee pain in Luton, and actually, if you had acupuncture, then the outcomes for potentially not needing that intervention were excellent, and people didn't need it. So all power to you on that. But I noted one quote that you said, which interested me, which was, if there's a paid-for option, people should be told about it. Now, I wanted to follow that up because, I mean, the frustration for acupuncture, maybe for others in the room, is that although we have an evidence base that's reflected by NICE, that hasn't been rolled out in terms of the NHS paying for it. So actually, most of our members work in the private sector, and we offer millions of treatments a year. But what members often say is that all they want is actually for their local GP to say, well, you could try acupuncture. Here's your local acupuncturist. And there seems to be some complication, which maybe you can help us with, that maybe some GPs take an unnecessary kind of sense of responsibility that if they're saying, well, try a British Acupuncture Council acupuncturist, they're taking some responsibility for that referral. But at a basic level, if you're saying a paid-for option should be something that people are told about, then that is very interesting for us. So any further comments on that?
Thank you very much, Nick.
Thanks, Nick, for that. I think that I think that the place that this starts is actually we have already have an incredibly complex mixed economy around health and social care. And because we've got social care as well, we obviously have a huge number of people within the social care system who are predominantly or fully self-funders. And actually there's a concern about quality in all of it. And there's something about the reality of that, which is about making sure people have properly informed choice, and both where they're getting a mix of NHS and other services. So, you know, I'm really glad we have common cause in that, and it's something that we need to explore more. I have to say it goes down not terribly popularly when you talk to NHS audiences about this, because they think it's about undermining the fundamental principle of a free at point of view service, and of course it isn't. And there's always been a mixed economy within the health service. That's always been the reality of the health service, and actually we're moving into a situation where there's more and more of that. But it is also about informed and educated choice, and that's why I also think this is so welcome, because actually what this is a way of giving some confidence to people and to other practitioners in the system that they can make those referrals. So I do think that this, you know, the voluntary registers thing is something to be welcomed in that sphere. So yeah, I think that's absolutely right. I mean, the NICE stuff. I met with NICE last week, and we were talking about how frustrated they're feeling about how few of their recommendations get taken up in practice. So again, you know, there's a standard that's set nationally, but actually people's access to those standards is very, very variable. And so one of the things that we were talking about is how we can empower local Healthwatch to make sure that they raise awareness amongst their own communities that people should and do have a right to access for NICE recommended treatments. So,
thank you very much. Another question? And we have the mic ready for you. Sorry, yes, lady there, thank you.
Hi, my name's Hazel Russo. I'm from the Complementary Natural Healthcare Council. This is sort of a practical question, really, about who makes up the local Healthwatch people. Who are the people on those bodies? They typically have 5 or 6 paid members of staff. And their roots, I'd say, are mostly in the voluntary sector and community engagement. So there are a number of people that hold support contracts for Healthwatch, Citizens Advice Bureau, Age UK, Mind, all hold contracts for Healthwatch. So the Healthwatch themselves are standalone organisations, but they are often sourcing back office support from those other organisations. And lots of voluntary sector and voluntary action organisations also host their local Healthwatch. So in terms of their backgrounds, there's a huge diversity again of their backgrounds, and they are quite new. So they were only born just about a year ago. So their birthday's coming up very soon, the 1st of April, and people have been drawn from a huge variety of backgrounds. But I just came from an event at Healthwatch Peterborough, and all of the Peterborough people and the Lincolnshire people next door to them are all voluntary sector people by background. Many of them have got a health and social care understanding and knowledge, but not all. So what they do really effectively, most of them, is reach very deeply into their communities and have ways of getting into the parts of the community that other people find hard to access.
And I wonder, Catherine, if you could just clarify for everybody the relationship between you at Healthwatch England and the local ones, on which we spent many a happy hour on the health and social care bill.
Yeah, indeed. Well, I mean, you gave us, not you personally, Jill, but the Act gave us a terribly complicated relationship, actually. So whilst we're the national body, we don't commission Healthwatch ourselves. They're commissioned by local authorities. So we can't performance manage them directly, but we lead. And we have the power of persuasion. We have a common brand and a common name, but we encourage them, and it is a very willing network. We encourage them to, follow our priorities and be part of our values and all the rest of it. But we don't have a direct command and control. But as I say, people tell me it's a very modern way of doing leadership. So hurrah for that.
Have we another question? Did I see a hand over here? I think we're at the sort of end of afternoon where people have talked out in the workshops, but I will take another question if we have one. Yes, over here, thank you.
Thanks. Okay. Carol Jones from IGA. What you're doing sounds absolutely fabulous. was a great lecture. Thank you for that. One sense is you're going to come up against opposition. There are Chatham rules today. Are you able to speak on that, and have you had some fairly ferocious opposition to what you're doing?
Ne'er a day goes past without having a slightly ferocious conversation. I think that's the kind of job of a national body. It's very interesting because there is it's a grown-up relationship that we need to have with the government for certain, because when as government you say let's set up an independent body to champion the needs of people who use health and care services, it sounds wonderful on paper, and then the bloody thing gets up and starts doing exactly that, and that all feels slightly challenging. But to give credit to both that we've got very strong backing from all of the political parties. So I was with Andy Burnham at the launch of Healthwatch Wigan, where again he reiterated to how, whilst they are going to, their intention is to scrap the Health and Social Care Act, the bit that he thinks was very important in it is Healthwatch, and we have him, in fact, on camera saying that, so we will play it back to him. So we have backing from all of the political parties, and we have very strong backing from the current Secretary of State and our Lead Minister Norman Lamb. And the civil servants, whilst they find it tough sometimes to manage that relationship, have also been grown up about it. But it's not without its friction, for certain. So yeah, I think that there is always going to be challenge in that, but in a way that, regardless of what one thinks about the rest of the Health and Care Act, there was a kernel of something very powerful in there, which is about full operational and editorial independence, and we do slightly have it tattooed on our foreheads when we're out and about, because that is the gift we were given, which is around full operational and editorial independence.
And I think, Katherine, that answer shows why you're such an excellent Chief Executive of Healthwatch England. I think we will draw this part to a close now, and with our most grateful thanks to you, Katherine, for such an excellent presentation and for answering our questions so ably. Thank you very much. Well, it falls to me to do the wind-up, but far be it from me to think that I could possibly summarise the richness of today's discussions in even 15 minutes, let alone in a couple. So I will just say that I hope that this first conference has at least started to achieve our objectives of sharing good practice for the AVR schemes and for promoting learning. I think some of that has certainly been achieved through our speakers, and I would like very much to thank all of the speakers who've spoken in the plenary sessions and in the breakout sessions for their excellent presentations. I was able to go around several of the breakout sessions, and the discussions were certainly very lively and engaging. So thanks very much to all of those. Thank you to all the PSA staff too, who've worked so hard on this conference and have enabled it to run so smoothly. So I'd like to thank all of them most sincerely. But as ever, the sharing of good practice and of promoting learning will also have come from all of you, from the networking that I think you've been able to do, from the networks and connections which perhaps have been established, which we can build on as we go forward. But I hope that you will agree that this first conference has been a very good experience. It certainly has been for us. I thank you very much indeed for your attendance and your participation. I will just say that we encourage you once again to tweet your experience today, remembering the Chatham House rules, and remember that the hashtag is AVR 2014. Now, I also want to say that all the handouts and slides that you've seen today and have been distributed will also be distributed to you. So don't think that you've missed out on the workshops that you didn't attend. So most of all, may I thank you all for coming and wish you a very safe journey home. Thank you.